Good afternoon, everyone. I would like to first thank Dr. Deepak and his team for inviting me. And our topic is newer oral anticoagulants. So we have to first go back to the history. So prior to 2009, warfarin was the only drug, and it was in use since 1955. It was very important, and it reduces risk of stroke in atrial fibrillation by 66%. It reduces the risk of recurrent events, complication and death from pulmonary embolism and DVT by at least 80%, and it also reduces risk of valve thrombosis and emboli in mechanical valve prosthesis. Despite such a wonderful drug, it was perceived as a bad drug, and there were reasons for that, because it has a prolonged onset and offset of effect. It is highly protein bound, and as we know that it is highly affected by diet, so modifications, and you have to take care of that, and there are many drug interactions with it, and there is a very large individual variation in metabolism. So exact dose for a particular person varies very widely, and there is a need for frequent monitoring. So you have to monitor INR at frequent intervals. And despite all these problems, good thing was that it works. It was cheap and it's not affected by renal functions. So what is the ideal anticoagulant? There was a search for the ideal anticoagulant to replace warfarin. So the ideal anticoagulant should have a wide therapeutic margin, infrequent oral dosing so that it is convenient to the patient, lack or minimum food and drug interaction. All the problems that were there with warfarin, it should not have been there. No need of monitoring, affordability. So today we have many anticoagulants available with us. So this is the classification: heparins, which include unfractionated heparin and enoxaparin, deltaparin, which we are using on a day-to-day basis. Then vitamin K antagonist, warfarin, and then newer oral anticoagulants, or also called DOACs, which have either direct thrombin inhibitors, and in that we have Pradaxa and argatroban. Pradaxa is dabigatran, and then factor 10A inhibitors, which have rivaroxaban, Xarelto, Eliquis, apixaban, and then edoxaban, fondaparinux, and vatixaban. Last two, and this argatroban is not available to best of my knowledge here in India. So coming on to the mechanism and site of action, as we have already read it in our physiology, this is the coagulation pathway, and so as you can see, these drugs act directly on the factor 10A, rivaroxaban, apixaban, edoxaban, and this dabigatran act directly on factor 2A, thrombin, and this is the site of action of warfarin. Warfarin act indirectly, and it is vitamin K dependent. So because of these actions, there were advantages that DOACs, these newer drugs, are having rapid onset of action and rapid offset of action. They do not depend on vitamin K metabolism. So they are not affected by vitamin K or food intake, and these are not reversed by vitamin K. So to compare the efficacy of these drugs with warfarin, there were many trials that were conducted. In patients of atrial fibrillation, 3 trials were there: Raleigh trial, Rocket AF trial, and Aristotle trial. These were on comparing warfarin with dabigatran, rivaroxaban, and apixaban respectively. So the main results were that in Raleigh trial, dabigatran 150 mg was found to be superior to warfarin in preventing embolic stroke, and complication wise it was equivalent. If we reduce the dose to 110 mg, then efficacy was same as warfarin, but risk of complications were less, and both the doses were associated with lesser intracranial hemorrhage. There is higher chances of GI bleeding, but that were not life-threatening. In Rocket AF trial, it was done with rivaroxaban 20 mg daily. It includes thicker group of patients, and the results were that it was not inferior in preventing embolic stroke. The risk of bleeding was same, and intracranial and fatal hemorrhage was less. Again, GI bleeding was more. Coming on to the Aristotle trial, it was done with apixaban 5 mg BD. It was superior in preventing embolic stroke, less major hemorrhage, less intracranial hemorrhage, no greater incidence of GI bleed, and overall mortality was lower. So, summarizing these, all these drugs were either as good or better than warfarin in preventing embolic stroke in AF. All were associated with either the same or lesser complication of bleeding, and all were associated with less intracranial hemorrhage, and these were associated with less, around 10% mortality compared to warfarin. So after that, clinical trials was done in DVT and pulmonary embolism. It's Einstein DVT trial and Einstein pulmonary embolism trial. In this, rivaroxaban 50 mg BD for 3 weeks followed by 20 mg OD was compared with enoxaparin BD for 5 days followed by warfarin to maintain INR of 2 to 3. And primary outcome that was observed was symptomatic recurrent pulmonary embolism. Again, the result shows it was not inferior in treatment. There was no increased bleeding risk, and so it was recommended that it's okay to switch to rivaroxaban after initial treatment with enoxaparin or heparin. So now we have NOACs and also warfarin. So which one we should choose? So we have to assess the patient profile. There are some advantages with warfarin because there is more data in elderly patient and in severe CKD patients it's not affected. Then there is we have the reversing agent available in the form of vitamin K, and in valvular AF this is the only choice we can use. In DOACs, the advantage we have already read. It's decrease in the risk of intracranial hemorrhage, dosing is better, fixed dosing, and fewer drug-drug and drug-food interactions, and there is no need to monitor anticoagulant status. So we can choose warfarin if the patient is stable on warfarin and creatinine clearance is less than 30. Renal dysfunction is there. In severe hepatic dysfunction, if the patient tend to miss frequent doses, and as we have discussed, mechanical heart valves, this is the only choice. Comparing, coming on to this NOACs, we have 3 drugs available mainly: rivaroxaban, apixaban, and dabigatran. Rivaroxaban and apixaban are factor 10A inhibitor, and dabigatran is factor 2A inhibitor. Dabigatran is a prodrug, bioavailability is less, and dosing is rivaroxaban is OD dose, while apixaban and dabigatran is usually BD doses. Monitoring is not required in either. So we have to see the patient profile, and then we can choose amongst the 3 NOACs. So if the creatinine clearance is 30 to 50, patient has renal dysfunction, so it's preferred to give rivaroxaban or apixaban because these are less affected by renal dysfunction compared to dabigatran. In ischemic stroke or on warfarin, again this dabigatran is preferred because of the least risk with dabigatran. In GI problems, apixaban and rivaroxaban, these are indicated because dabigatran is associated with dyspepsia in up to 10% of cases. In recent GI bleed, apixaban is the preferred drug. It has the least GI bleeding incidences. And in case of CAD, apixaban or rivaroxaban is preferred one. And in poor compliance, we have discussed already, rivaroxaban is the only drug which can be given in the OD doses. Coming on to the FDA approved indications. So all these NOACs are FDA approved for atrial fibrillation, that is non-valvular, then DVT prevention, and then treatment of DVT and pulmonary embolism. They are not FDA approved in post-MI. So these are again the consideration when you are prescribing once daily dosing or twice daily dosing. Xarelto for atrial fibrillation and DVT prophylaxis, and after first 21 days of therapy for pulmonary embolism, it can be given OD. Endoxaban we don't have. This is usually given OD dose. Betrixaban also, but that is we don't have. And Eliquis is given in the BD dose for all practical purposes. And again, considering food with or without food, Eliquis and endoxaban and dabigatran, these can be given irrespective of food, with or without food. But Xarelto you have to consider because it should be given with food only, specifically in treatment of DVT or PE and in AF. One important thing to consider is that dabigatran should not be broken or crushed because it increases risk of bleeding significantly. Dose modification are required in cases of all these three drugs. Standard dose for dabigatran is 150 mg BD. If the creatinine clearance is 15 to 30, you have to reduce it to 75 mg BD. Rivaroxaban again, it's 20 mg OD, and creatinine clearance is low, then you have to reduce it to 50 mg OD. And same apixaban, standard dose is 5 mg BD, but if the patient has either two of these three, here we are not considering creatinine clearance, it's serum creatinine more than 1.5, age more than 80 or weight less than 60. If 2 of 3 is present, then you have to reduce the dose. These are the doses for non-valvular atrial fibrillation. Again, you can see that most of these drugs you have to reduce the dose if the creatinine clearance is 15 to 30. And at less than 15 ml per minute creatinine clearance, you have to avoid these drugs. And these are the doses in treatment of thromboembolism. You don't need to remember it, you can make this. And again here, it's if creatinine clearance is less than 30, it is saying to avoid using these. These are the doses for DVT prophylaxis. And here again, Eliquis, there is no requirement for changing the dose. And this is the thromboprophylaxis in those patients hospitalized with acute medical illness. The preferred drug in these cases, betrixaban. And again, dose modification is required as per the creatinine clearance. And this is the dose for reduction in the risk of recurrence of DVT and pulmonary embolism. Again, if the creatinine clearance is less than 30, it is advised to be avoided. Eliquis can be used. So after this, to assess the patient's benefit, there is a score that is given. This is called CHETS to West score. So this is to assess the benefit patient will get by giving anticoagulants. So this has congestive heart failure, hypertension, age, diabetes, stroke, vascular disease, age and sex. Sex female, 1 point is given to all except age, which is given 2 points, and stroke, which is again given 2 points. And they have recommended that if the score is more than 2, it is recommended to give anticoagulant. If there is score is 1, patient then you can give, and you can give aspirin also. If score is 0, there is no need to give. And then there is a HAS-PLAT score, which assess patient for the risk of bleeding. So here again the points are given: uncontrolled hypertension, then abnormal renal functions, bleeding tendency, then labile INR, elderly patient above 65 years, and drugs like antiplatelets and NSAID. Here if the score is more than 3, this is high risk, and you should assess the patient whether you should give anticoagulant or not. And there are modifiable factors, so you can try to control hypertension, and if you can stop the drugs and you can reduce the score, and then you can decide to give your anticoagulant. So in practice, if you are to prescribe anticoagulant, there are few things you should keep in mind. First is abnormally low weight, because you will be requiring dose reduction. Bleeding risk, specifically if there is a recent GI bleeding, because in this case there is high chances of risk with dabigatran, and you will prefer to give an alternate drug. Then creatinine clearance, for all the drugs you need to modify the drug dose, then drug interactions, and elderly age. Coming on to stopping, when we are encountering this on day-to-day basis, patient require a procedure and we have to stop the anticoagulant. So there are three categories. Few procedure you do not need to stop the medication. Then there is a low risk group and there is a high risk group. So procedure which do not require interruption of medications are dental procedure, extraction of 1 to 3 teeth, periodontal surgeries, abscess incision, implant, and cataract extraction, endoscopy. If they are not doing the biopsy, then superficial surgery like dermatologic excision. In these cases, you do not require to stop the NOACs. Then low bleeding risk, endoscopy with biopsy, prostate or bladder biopsy, RFA, angiography, cardiac catheterization, pacemaker or ICD implant. Then in major risk, complex left side ablation, spinal epidural anesthesia, lumbar puncture, thoracic abdominal surgeries, liver kidney biopsy, then major orthopedic surgery, TURP, and most neurosurgical procedures. So after categorization the patient, you can refer to this table, and as per the creatinine clearance you can find out for how long you need to stop the medication before it is safe to go ahead with the procedure. Monitoring wise, there is no conventional coagulation assay like APTT, PT, INR, which can monitor NOAC efficacy. Some of the assays will be affected, but we cannot predict to how much level. So comparing with warfarin, which need a lot of monitoring, warfarin need INR at least monthly, more frequently if patient has severe kidney disease or there is a change in condition, diet or medication regime. CBC at baseline and annually is required both with warfarin and DOACs, and serum creatinine at baseline and 6 months for both warfarin and NOACs. Reversal, again, vitamin K is not of any use, FFP does nothing, prothrombin complex concentrate may be beneficial but it is expensive. So in case of warfarin, to reverse you have to first withhold the dose and then monitor INR, and oral vitamin K is now only recommended with INR more than 10. If there is a major bleeding, you should shift the patient to the hospital, start vitamin K, and you can use PCC and FFP. In case of NOACs, only dabigatran has reversing agent, which is Prexbind, idarucizumab. It is approved since October 2015, and again this is only for dabigatran. There are other agents which you can see. These are antixanet alpha. This is a truncated human recombinant factor 10A that binds and neutralizes factor 10A inhibitors and also low molecular weight heparin. And then siraperantac, which binds directly to any of the DOACs, LMWH or fondaparinux. Again, idarucizumab is given 2 doses of 2.5 gram each at the maximum 15 minutes apart. So that is brief overview of anticoagulants. Any questions? So we can take few questions. So which is not true for NOACs? Less drug and food interactions, no need to monitor INR, readily available reversing agent, and lesser risk of severe complication including intracranial bleed. Yeah, so readily available reversing agents. Following are the FDI approved indications for NOAC except atrial fibrillation, DVT prophylaxis, treatment of DVT and post-MI and unstable angina. Following are the NOAC trials in AF except Einstein trial. Which is preferred NOAC in case of recent GI bleed? Then, yeah. There is no need to stop NOAC before following the procedure except lumbar puncture, yeah. Okay. Okay. Thank you.
Thank you, sir.